If everyone wants to take a seat, we will get started shortly. There's several open seats on this side of the room and our balcony as well. First, I want to thank everyone for being here tonight. I'm just going to go through a few housekeeping items before we get started. Both sides of the room, the doors are unlocked, so you can come in and out without a badge. Same with upstairs. If you walk around to the back side of this room, there are restrooms behind us on the first and second floor. There is a bar in this corner, so please help yourselves throughout the night. And during the panel session, we will have a Q&A opportunity, so please make sure you use the mic in front of you. You just click the speak button, it'll turn green. And that way our guests on Zoom can also hear the questions. I would like to introduce our president, Dr. Kimberly Long. She'll get us started tonight.
Well, good evening, and welcome to the 2025 Frontiers in Medical AI Summit, hosted by the Kansas Health Science University and the Medical Society of Sedgwick County. It is wonderful to see so many of you here in person and those joining us virtually this evening. Events like this bring together educators, physicians, innovators, and community partners, people who all share one common goal: to improve the health of Kansas and beyond. At KHSU, we are proud to partner with organizations like MSSC to provide opportunities for our students and faculty to engage with the greater physician community. We are preparing future physicians. Those future physicians will become your colleagues, and through collaboration, we all grow stronger by expanding our knowledge, networks, and our capacity to care. We are so pleased tonight to feature two incredible speakers whose work highlights the promise and the challenges of AI in healthcare. Following their talks, we'll host a panel discussion. We are going to feature the two speakers this evening and two local physicians who are using AI right here in Kansas. So now, to help open this evening on behalf of our co-hosts, please join me in welcoming the president of the Medical Society of Sedgwick County, Dr. Johnny Musa.
All right, guys, I have good news, bad news. The good news, my term is finished in 2 months. The bad news, because of that, I'm gonna talk. All right. It is an honor to welcome you to this special AI Medicine Summit presented jointly by the Medical Society and the Kansas Health Science University. Tonight, exciting moment for our medical community. For more than a century, medicine has evolved through discovery and innovation, from stethoscope to CT scan, transplant, antibiotics, and now we stand at the threshold of the new era, one where artificial intelligence becoming part of our daily medical practice. Ask my brother, ChatGPT and Ronnie. AI is already here. We know we analyze radiology image, we flag early changes in lab data, identify drug interaction, we even help us complete chart little faster. Some of those tools are subtle, almost invisible, but they are changing the way we care for our patient, very quietly, efficiently, and profoundly. Yes, as impressive as AI may be, it is important to remember that the true power of medicine never been in data or devices. It has always been in us, people. AI can analyze pattern, but it cannot comfort a worried patient. It can detect abnormality, but cannot hold a hand of a worried patient. It unspoken fear in someone's eyes. You cannot ease that by AI. The art of medicine, our empathy, our ethics, our human connection will always be what gives science its purpose. That we are gathering like this matters so much. They give us the opportunity to pause and ask, how can we integrate AI in a way that enhances what we do without losing who we are? Here in Wichita, we're uniquely positioned to lead this conversation. We're large enough to innovate, but we're small enough to stay personal. I know us as a physician, we know our patient by names. Medical schools are eager to explore new frontiers and hospitals that are ready to pilot new ideas. This summit will bring together clinician, educator, researcher, and developers, all sharing one goal: to make AI a trusted ally in our mission to heal. You will all hear specific example of how AI is being used to assist and enhance care. But beyond the technology, I hope you will also hear something deeper, a call to shape the future of medicine with both intelligence and heart. As we begin this evening, I encourage you to be curious, challenge assumptions, imagine how this technology might help us focus more on what really matters, our patient. I really want to thank our partner in Kansas, COM, and everyone who helped make this event possible. The collaboration between our medical school, medical society, our practicing physicians reflect the best of Wichita, a place where innovation meets compassion and where we continue to care for patients as neighbors, not numbers. Together, we can ensure the future of medicine assisted by AI remain human at its core. Thank you and welcome to the summit.
Well, that was a lesson in courage. I am much too short to go right down the front. Thank you, Dr. Musa. It is my pleasure to introduce our first speaker, Dr. Sarjoo Patel, a physician entrepreneur whose life and career embody the mission of this summit: to reimagine healthcare with innovation, humanity, and even joy. Dr. Patel is the founder and CEO of Beam Healthcare, a telemedicine organization dedicated to leveraging technology to expand access, reduce unnecessary patient transfers, and bring a high-quality specialty care into communities that have been underserved. Before founding Beam, Dr. Patel built his foundation in both medicine and technology. He holds a degree in operations management and information systems, and then went on to complete his medical training, ultimately working as a hospitalist, serving in critical access settings. Sometime after founding Beam in 2013, Dr. Patel had a life-altering near-death experience. That event framed and reframed his mission. He resolved not merely to survive healthcare, but to lead its transformation. Under his leadership, Beam now spans multiple states, is Joint Commission accredited, and provides telemedicine and services across specialties, from cardiology to neurology to dermatology to pulmonary care. Through his work with Beam and its nonprofit arm, Beam Up, Dr. Patel has also committed to social impact, delivering care access and education to youth in under-resourced areas. Tonight, Dr. Patel will present From Surviving Healthcare to Loving It Again. He will show how innovations influence telemedicine, AI, robotics, and how even holograms can help us move from burnout and friction towards a future where clinicians feel energized, empowered, and renewed in purpose. So please join me in welcoming Dr. Patel.
Okay, we're good. What was that?
The AI is not working.
Oh, it's working. It's working. All right, let's put this up. Well, thank you for the intro. And just going to get started here. It's about in the last 3 weeks, I had about 2 patients that said, Doc, would you pray with me? And can I pray for you? I'm not a religious guy myself, but half my family is Hindu, half is Christian. I know what faith means to them. I know the importance it has to share that with someone else. We'll get to this story here in a bit in terms of where this all came about. So just hang on and we'll get to it. You know, I think all of us here are here for a reason as clinicians. And, you know, as we mentioned earlier, I was a tech guy, I was a business guy, zero interest in going into healthcare. The word clinician, the roots come from the Greek word klinikos, which is being by the bedside. And over time, that evolved into the art of medicine. And I think that, you know, seeing people helping each other has always meant something. Well, once again, I had zero interest in healthcare. Before we continue this, what I would like everyone here, I see we have students, we have people who've been here for 50 plus years, have been practicing. I want everyone to go ahead and close your eyes. I see all doctors close their eyes. There you go. And just ask yourself why you joined medicine in the first place. Go back to when you first started that dream. Just think of that moment and not the obstacles that we currently face, but just hold on to that memory. All right, go ahead, open your eyes. You know, for me, it was in undergrad, my senior year, I lost my best friend. I had a couple family members end up in the ICU. So it was about helping the people is what made me pursue healthcare. So that's why I went. It was a social impact thing. It had nothing to do, that was my first preference. I'm still a business and a tech guy at the core, but that was my why. And you know, Dr. Musa, you mentioned something which I want to go back to. Being a clinician is the art of medicine, right? And that has always been a special place for me as well. And it was time for me to go ahead and practice my art of medicine. In 2009, our attending physician takes me, or a bunch of us, to a nursing home and says, all right, go talk to these 3 patients. You cannot examine them. You cannot open the chart. And give me the top 3 working diagnoses. And when we just looked at him like, okay. So we came back and then we had a discussion. And that showed us the value that if you truly bond with a patient, the history you get is much deeper. The connection you make is the intangible. You know, if you want to create the Mona Lisa, it's not just the labs and imaging paintbrush. It is the intangible of that relationship. And that is what he taught us. But also, the other part was, majority of the times, you are going to have a diagnosis worked out, and everything else just supports the diagnosis. So that was a very important thing for us to learn. And I'm grateful for that attending, who is probably one of the smartest guys I've ever met. Now, fast forward, I didn't call it current reality, I called it recent reality, because I feel like for the last 20 years, it's been the same conversations about what healthcare is and what EHR and all these things. And it stopped being art, and we're just doing, at times, administrative stuff. And listen, I could care less about how fast I type. I could care less about bullet points on my notes, right? I just want it to be done. And I was talking to one of my colleagues literally last week, and he's an ER doc here in Kansas. And the reason I have this, the Pit, I have never seen that show, but he told me, he's like, hey, have you seen it? I'm like, no. He's like, man, you know, watching that just reminds me of why I love ER, right? The things he's doing in there, I mean, that is why I joined. And then he was talking about his EHR they had, which is horrendous and whatnot. And And he's like, but you know what? I realized the reason that guy is so happy in that show is because I don't see him behind the computer. So, and that is the reality, right? So the question is, whenever you see an issue, something's working well, something that's not working well, I think we should ask the why, right? Why are we at this place? It's because the US healthcare system has just been built on an analog, old school healthcare system, right? And does anyone know these three photos, what they mean? Oh, look at that. Stump the docs. Huh? Yeah, so the thought process, and its majority is true, which is the space shuttle boosters, the size of the boosters were decided based on the width of the railway tracks. The width of the railway track was decided based on the horses behind, okay? So we need to understand, just because something exists, like why does it exist that way? And currently, I mean, since I was in medical school, I've heard this cost, quality, access, iron triangle for years. Nothing has changed. It's the same old conversations. And I don't use the B word in terms of the burnout of the physicians. I think it's a whole different topic. It's not burnout, it's just productivity and respecting someone's time. So I just want you guys to keep in mind that if you're making any decisions, don't do it on a legacy system, okay? And ask the question of why. So in 2013, I was 2 years into my hospitalist directorship. They had hired me as a hospitalist director to keep more open ICU patients locally, avoid transfers to the city. And we did that. We strapped it 24/7, and we were successful. But I knew it wasn't feasible financially for this hospital to have 24/7 physician. It just wasn't. So I had all these tech ideas. I was in, all these order sets and committees, et cetera. We did all of that. So 2013, 6:30 in the morning, I'm going on the back roads of Wisconsin, driving to work. On the other side, there's an SUV that goes into the gravel, overcorrects, comes directly towards me, and missed me by a nanosecond. And if I was on the phone, I wouldn't be here. And that happens. I see the car rolling in my rear view mirror. and I stop and I run towards that car, right? I'm seeing the guy who's mowing the golf lawn, and he's like frozen over there. I'm going towards the car. Unfortunately, the person ejected, and they were in the middle of the street, and I'm working on them. I see a bunch of toys laying around. I tell the guy to go look for kids. Thankfully, there are no kids. After all that was done, the person did not make it. I was talking to the cops, and then I hear a scream from the other side. And that person said, it just said Dr. Patel, and I find out the person who unfortunately passed away was a significant other of my colleague at the hospital. They were very thankful that I was there, and their family didn't suffer. I went to work, saw my patient still, and then about 2 or 3 o'clock, I go to another med exec meeting, etc. And I just felt completely numb afterwards. It was more so, hey, I may have lost my life. Well, someone lost their life. And my obituary would have said, good doctor, good kid, good friend, good brother, whatnot, right? Which is fine. I'm not here from my legacy perspective, but it was saying, but what did I do to help my community? What did I do why I joined healthcare, which was a social impact side, and what did I truly do? And my answer was, I didn't. What was capable? So that is where I said I would rather chase my dreams and fail forward and persevere versus living a complacent and an average life, put it that way, meaning I didn't try my hardest. And by the way, these drawings are me. The Toby the Dobie is our dog who passed away, so don't make fun of my illustrations. So what I did was then I told the hospital, I'm going to go ahead, if it's okay, take my directorship away, but I want to start a company, and it's going to cost you less, and I'm still going to have the highest level of quality for you. And the way we're going to do that is by leveraging technologies, one, and like I said, that was my core, that I knew. I was going to leverage a core team because you often see a lot of locums folks go in and out, but they're not dedicated to the community. So I wanted full-time, part-time folks to be part of this. And I wanted lean operations so the company was going to be paperless from day zero, because I knew it was important for admin and clinicians to be efficient. And I want to leverage their time where they mean the most at the company level. So that's what it was. Thankfully, they gave me a chance for a 1-year pilot, and we're still with them. Daytime on-site hospitalist, nighttime has been telehospitalist, where we admit people through it, cross-cover and med-surg and ICU. And since that time, Beam's evolved into multiple specialty services. But that time, same questions, telemedicine, and I think you hit on some of it. Is it personal? You know, can the quality isn't going to be that good? Our community won't accept it. And you can't take care of complex patients. So I've heard this over and over, and it's right for people to ask these questions. I will say, we started in rural Wisconsin. My first patient was a 90-year-old grandma in the ER. I go to see her on the robot. She looks up there and she's like, is that Dr. Patel up there? Because I knew her from before, and she broke the ice for me that me and her did not lose connection, okay? So that was proof right there. Half my company, physicians were not okay taking care of patients, admitting them or on the ICU. And I told them that is okay. Let us prove it. Not a single person left. Everyone joined. Everyone did telemedicine. But they had to see it, experience it. You can't force it. And there was a doc, I remember at one of the hospitals, whereas Beam was expanding, he said, there will never be a robot or telemedicine in this hospital as long as I'm the director, as long as I'm alive. And that was fine. Fast forward, you know, COVID happens. During that time, our telepulmonologists, our telehospitalists, our telerespiratory therapists, we all volunteered for about a year and a half to support multiple hospitals. There's no cost to anyone. We just did what was needed, including his hospital. So, and I think people see the value once you experience it. I think it's the way you communicate and the goals. And since that time, like, you know, we've been nationally recognized in Inc., paperless, like I said, from day zero in terms of operational efficiency. And, you know, we also have a nonprofit, Beam Up, that post-COVID, we had 4 different orphanages in Tijuana that we helped provide care to about 120 kiddos, and also in Papua New Guinea. And this is just the proof of concept is all I'm trying to tell you. That someone has to take a chance on you so you could do a proof of concept. And I wanted to go ahead and first just show you a quick video so people kind of understand. And by the way, we are tech agnostic in terms of the equipment we use, but just so you have an idea from one of our clients.
I'm looking at us being in rural Louisiana. It was important that we have the best providers come and provide services here. And the best way to do it was, and cost effective, was to do it through telemedicine. I think it was outstanding for us to network and work with a company like Beam Healthcare. We have them here 24/7, rendering great healthcare to our community here in Morehouse General.
Whenever the doctor decides that we have a patient that needs to be admitted, we notify them, and almost, you know, very quickly they respond and call back to the doctor or come in to see the patient almost immediately.
Telehospitals have been more positive than standard office-based practice. They provide patients with the best quality care with diagnosis and treatments.
So I want to go through this, it's 2.5 minutes long, but you get the idea that we're in rural Louisiana with a self-driving robot. How are people going to take it? It all comes down to how many touch points we have with the patients. We see them sometimes 3 times a day, right? I could admit them, I will round on them, go talk to them in the afternoon, go talk to a family, but I'm able to see them multiple times a day. And that is what changed it. And purely for the business folks here, ROI from a financial perspective, you know, one of the hybrid telehospitalist program, they went from about 12 million in revenue to about 24 to 25 million in 5 years, inpatient revenue for a small hospital. And the way they did that wasn't just all medical, but because the hospital service was there to take care of sicker folks, that's when everything around it grew. So podiatry, orthopedic, general surgery, everything grew around it. And that's the way to think about it. What can you leverage to grow things around? Not necessarily what can I get? Can I get my money back from just one thing that I'm going to implement? And that's the bigger picture. And obviously, since then, we now have AI, we have robotics that people talk about, and also I think Google also has the hologram communication tool. And by the way, Google called 2 of their companies Beam and Flow. Those are exactly my company names, so it's made it very hard for us to kind of compete against them with those names. But with the AI and robotics and the holographic, right now, everyone here and elsewhere, they're trying to figure out, what do I do with it? What do I need to, what should I implement? What shouldn't I implement? And what's scalable? Number one thing I would say as a tech guy, don't just buy into like the shiny object or a whack-a-mole solution, okay? Or you'll just end up with a bunch of AI tools, okay? And then you're just in the same thing where you're just kind of building without a foundation. And the way we do it, and that's what I would like to talk to you on how we implement it at Beam and the process that we take. So it is a very engineering and tech kind of a process, but it's very simple. So the only thing matters from a business perspective in terms of what you're trying to improve is the patient's journey or the team's journey. So it could be the provider's journey in terms of every day. It could be the administrative staff's journey every day. And that's called the user experience, user journey, called UX when someone is developing a software. Because you want to make the user experience the best experience possible. And I think that is what's lost in the current US healthcare system. Doctors, nurses, no one cares about that. They just put a little feature for you to make life a little bit easier. But that doesn't equate to an improved user experience. So user experience 101, all you do, you need a whiteboard, draw a line, left is start, right is end, right? And for example, if you were to take a provider's day starting at 7 a.m. to 5 p.m., for example, you mark every single touch point, from reviewing charts, from calling, from documenting, from physical exam, every single thing you document. This is not a 30-minute exercise. This actually takes hours, because the only way you perfect user experience is you go through all the tasks, all the touch points, and every little thing. But now the question is, what do you need to keep? What do you need to modify? And what do you need to get rid of? Just because you do it now, that doesn't mean you have to continue doing something. I think this is where I personally use effort and impact matrix. So meaning, if you have all of these tasks that you have to do, if something is low effort and it gives you high impact, you should be doing that every day, right? Meaning it has a very high ROI for you or for your business, whatever, and the effort is minimum. Those are the green things you should never get rid of. But if something is very high effort and has a low impact, those are the things you need to get rid of that noise. Okay, and this is an exercise because a lot of times you go to a meeting, depending on who you're talking to, everyone thinks everything's important. And the next thing you know, you have a list of like 30 things that haven't changed. But eventually you do need to get rid of the noise. And this is an important thing to understand what your task and priorities are, because this now takes you to the next step on what do you do about all these things that you want to achieve or improve. So one thing, if you don't have it at your organization, I would highly recommend in your annual strategic plan, don't just call it staff, call it staffing, call it augmented staffing strategy, which is who is truly people working for you overall. And the way to think about it, obviously you have the on-site staff, clinical and admin. You have the virtual staff, clinical or admin, from like telehospitalist, telespecialty, but then also virtual assistants. Now you have AI, that could do simple tasks or complex, some agentic conversations. And then you have robotics, which are improving pretty rapidly as well, and they're trying to go to bedside patient care. All right. So the way to think about your team, now robotics isn't cheap enough yet for everyone to afford it, but it will be. All right, it will get there. So even if you focus on the top 3 right now, this is where you take the task and all your priorities and figure out who could do what. And that's a whole different conversation, and we could take a deeper dive on that one. But I really hope that when you think about your team, this is your team overall on how you could go ahead and provide care. So in 2024, like I said, we were already paperless at Beam. But my goal is always to think, how can I make my providers, my team, more efficient? Employee retention is key. Some of these folks have left their on-site jobs to join us with us full-time for telehospitalists. I want them to enjoy their work, but because that translates to better customer service to the patient, that translates to better customer service to the client. And the way I've always thought is what's happened in the last 20 years is we went through evolution, but devolution is kind of what we've kind of gone through, and like we're just shackled, right? And the way I've thought about AI is my personal assistant that's going to help me free things up, even if the EHR and other systems aren't there yet, right? So what did we do at that time? And we use the augmented staffing model at Beam. So I'm going to give you my example as a hospitalist, how my day looks like, telehospitalist or on-site hospitalist. In the morning, I know how many of the patients are going to, most likely go home, how many is possible, but majority of which ones are staying. So I'm going to let my human scribe/assistants know that, hey, these 10 staying, these 3 discharges, this one's possible. So I've already kind of given them a heads up. They start preparing my notes. I go see the patients. I have my AI scribe, and there's a dime a dozen AI scribe stuff now, right? I go ahead and put a summary for all of my patients in it, in terms of the plan, the to-dos, and you could create your own template. But anyways, all I do is I've dictated it, and then I go ahead and copy and send it to my human scribes. After I'm done, by the time I touch the computer, AI has already gotten between AI and human scribe, my note is 98% complete. So when I touch the note, I literally have to edit very little. I think one thing people have to keep in mind, what tech struggles with is the last mile, like Amazon struggles with the last mile of delivery, okay? AI scribe is nowhere near where it could actually take on that last mile yet, okay? So, and that is where humans are needed to put pieces together. But also you could format it as you like for your notes as well if you don't like the AI formatting, so you could do that too. But to just know that what that has done, documentation, but let's say if I'm talking to a patient and their families and they have questions about some microbiology stuff or some lab work, I text my team on the side, they're looking at the chart. So the scribes I've hired, they're not just scribes, they're actually scribes and assistants. So they tell me, hey, creatinine was so-and-so and now it's improved. So even if I don't remember, I don't have to go log in and look, I just ask and they're real-time assistants, they're available to me. And the reason I want to say all of this, I spend the bare minimum time on EHR because we've spent so much time on ensuring the order sets, the subset order sets, dot templates or dot phrases, et cetera, are in place that we could leverage it to be efficient hospital or specialty. And that is what made me have time for my patients, those 2 that told me that they want to pray. The day before, the gentleman, him and I only talked about his disease, what he was going through. We talked about why this may have happened and what it needs to be done. And that was it. We didn't have any specific deeper conversation, but we had a good conversation. And I had the time to do so because ops was on my side and we were efficient. And the other patient, we talked about her issue. She honestly asked me a lot more about my kids and we talked about family and that's what we did. So when I went there the next day, we had connected. And I'll tell you, they asked to pray together, but both of them, which hasn't necessarily happened, they prayed for me. And one of the gentlemen, he said, give doctors the resources and the support that they need to take care of the community. And I just thought, I was having a hard day that day. I mean, it was just, but it was nice to just hear it. I didn't necessarily need it, but it felt good. And that is what I want for all of you to think about. I don't want you to just think about what's out there in terms of the softwares people release or what the big companies do. Just know that if you shift your mindset on tech, if you shift your mindset on team, the very basic one sentence I would tell you, leverage it to amplify your impact, right? That is the way to think about it. And that to me is, from a social impact side, from community side, is what means the most. And I appreciate your time. If I could show you.
All right. Our next speaker is Nicolas Sandros, a seasoned leader at the intersection of data, AI, and intelligent automation, currently serving as managing director in the data and AI practice at BDO USA. Nicolas brings a rich technical and leadership background spanning software development, systems integration, and business transformation. His expertise includes ERP systems, robotic process automation, data analytics, and designing solutions that streamline operations and reduce complexity. In his current role, Nicolas leads AI and automation initiatives designed to empower organizations to be more efficient, resilient, and responsive. He is passionate about how data-driven systems can help professionals reclaim time and energy for what matters most. So tonight, Nicolas will invite us to reimagine the clinician's workday. Imagine replacing chart chasing, fragmented follow-ups, and administrative inertia with seamless automation and intelligent workflows. The vision he will share shows how AI can fade into the background, restoring focus, connection, and time for care. So please join me in welcoming Nicolas Sandros.
Thank you. Sorry, just having a lag issue. Hello, everybody. It's not coming on. It's coming. Sorry about that. Should have had it on for. It's not AI. I heard that. Here we go. Apologies about that. All right. So, hello, everybody. As I was introduced, Nicolas Sandros. In my role, I work with a lot of companies. My team specializes within our group. We have a lot of healthcare coverage, but we also talk a lot about finances. So, on the admin side, we help a lot of groups take care of, all kinds of functions from that perspective. But today, what I wanted to do is to cover, let's get that. Imagine, a day when a physician starting their day at 7 a.m., they're an outpatient clinician. This Dr. Smith right here is arriving early, juggling a lukewarm coffee, but no, actually she opted today for a mango refresher. I like those better actually myself. She's got the phone in one hand buzzing, missing messages, and then she's just trying to, get her way in. She wants to feel ready, steady, go about her day. She gets in, sits in front of her laptop, flips it open to see. And what she sees, instead of walking into the exam room, she starts to see an overwhelming inflow of labs, imaging, results, patient messages, unfinished follow-ups that she's having to keep up with. The waiting room is starting to actually get filled up, right? But she's trying to see what she get catch up on before it gets falling behind. But she can't, shake that feeling that I better get going. I cannot be catching up, right? This isn't a matter of laziness, really. It's a reality that thousands of clinicians face on the daily. They train to connect with people, yet are buried under an avalanche of charts, clicks, and clerical tasks, right? The truth is quite stark. Studies show that outpatient clinicians spend up to 50% of their time doing administrative tasks. Half the time isn't about patient care, it's paperwork, right? Documentation, toggling between screens, going through multiple systems that don't connect to each other, right? Now, if we jump ahead here, that weight of the clinician on the 50%, sorry, I didn't step ahead. Let's name the 4 biggest burdens, right? As far as the challenges that are facing clinicians, we have administrative burden, scattered systems, missed delayed follow-ups, and burnouts. If we start digging in on the, go back. If we start digging in administrative burden, imagine spending your evening finishing your notes while your family's eating dinner, right? Without you. For many clinicians, this is an actual, it's not unusual for them. It's actual routine that's happening on the daily, right? Then you have yourself scattered systems, right? There's labs in one system, imaging in another, referrals in a third, logging in and searching. Each eats up a lot of their time on, many hours each week, right? Then you have the adapting to that change, right? Missed or delayed follow-ups. Oh, did I skip ahead? Sorry. Yep. Missed and delayed follow-ups. Okay, this is going the wrong direction. Sorry about that. Okay, back up. All right. Missed and delayed follow-ups. Referrals lost. Teaching not documented. Discharge instructions that never get reinforced. Each gap in pace is a patient risk. And every miss weighs in heavily on the clinician's conscience, right? This solves, I know there was a mention about not mentioning burnout, but burnout is a realistic thing with mental load fueling exhaustion. Not because clinicians really stopped caring, but because the system is making it harder for them to care, right? I once shadowed a physician who spent 13 minutes trying to find a note from a patient. That's usually the average time that they can spend with an actual patient, right? But here's the hopeful part, right? For decades, clinicians bent to the rigid systems, learning how to click here, how to document, how to fit into that technology's limit, right? But those limits are quite expanding now. Now we're entering a brand new era, a very different era, an era where systems with help of AI and automation adapt to the clinician, where the system serves the human instead of the human serving the system. Now, those rigid systems have been breaking and then things have been progressing from the AI-driven side. There's a lot of thinking that has to be thought about. All of these agentic AI agents out there that are coming out, there's a lot of buzz around those words. AI agents in themselves are nothing without you, the subject matter expert, to train those agents, right? You're still going to be the artful piece of that, the last mile, as it was discussed, getting us to that point. But without, those agents are just simply brains. They're mimicking our procedure process. You still need automation, robotic process automation, to actually give it arms and legs, to connect to the EHRs, to the EMR systems, to the billing systems or CRMs, or whatever it is that you're trying to connect to be able to get in and expedite that workflow for you, right? So here's the AI-enabled future. Here's the vision of AI and automation in care. Picture that same 7 a.m. start, but with AI woven in the day. A morning snapshot agent that pulls vitals, labs, imaging, and orders into a single digest. Systems like Epic's in-basket summarization paired up with Microsoft's Azure Health Data Fabric deliver that today. It's not a vision of the future. It's happening today. A one-page digest of critical patient data, prioritize urgent labs, and predictive models highlighting risk. With AI flagging clinical overnight labs by morning, a routine outpatient check turned into a life-saving intervention, preventing an ER trip before the day even began. You move on to smart scheduling. Oh, I'm really bad with these. Should have had AI listen to me and then move it ahead for me instead of me doing it. Smart scheduling and coordination. Teaching, referrals, discharges traditionally slips through the cracks. With tools like UiPath bots handling the route referrals, Oracle Health, formerly Cerner, AI tracks follow-ups like Nuance, DAX, Orchestrate, closes that loop. Referrals are auto-routed to specialists, follow-ups are tracked, nothing is missed. Discharge codes are properly coded. A patient's referral processed same day, cardiology visit in 48 hours, and heart disease caught early. Those are like the benefits of that, right? So real-time clinical insight is very key. In the past, eyes down, typing furiously. Now, while with a patient, the AI assistant listens in. Those scribe tools have gotten better and better, not to intrude, but to help. A clip-on transcription tool captures the conversation naturally in the background. Tools like Nuance, Dragon Ambient Experience listens quietly. They draft notes, suggest codes, flags drug interactions. Early adopter clinicians are hearing from their patients, you're looking at me again, right? That whole restored trust and connection is happening, right? What does this mean overall? Snapshots give clarity. Real-time insights restore presence. Scheduling ensures nothing is lost. Not just efficiency, but ER trips are avoided. Referrals not lost, patients truly seen. This is in the future, as I said, these are tools that are available today and ready. And here's the payoff. 20 to 30 minutes per clinician per day can be saved. That may not sound like much, but across thousands of clinicians, that's thousands of hours reclaimed for care, teaching, and compassion. Alone in Kansas, 4,333 hours each day can be saved. Right? Now, let's picture Dr. Smith again. She walks into her first exam room, calm, prepared, and focused on her patients. She isn't typing furiously. She's not distracted by tabs. She's present. And the patient feels it. The difference isn't subtle, it's transformative. Again, this isn't about technology. It's about restoring humanity. Less chart chasing equals empathy, more empathy. AI scribes equal more eye contact. No missed follow-ups equal fewer visits. And supported clinicians stay longer at their jobs, protecting patients and the system. So the question we should be asking today isn't, should we adopt AI and automation? The real question should be, how quickly can we get these tools into the hands of clinicians who need them most? Because at the end of the day, this isn't about AI at all. AI is just simply there to help. It's about people, about giving back time, focus, and energy, so that every Dr. Smith do what they do best, which is taking care of their patients. Now, I want to expand a little bit about your understanding of agentic AI. You'll hear a lot of buzzword about agents and how they are going to be helping everybody, and there's like we should be jumping on the bandwagon of agent. It's all true. They are fantastic. The evolution that we've seen in the last year is moving at such a rapid pace. It's actually evolving on hour by hour, right? There's so much change that's happening, right? But what is really good to understand is I only highlighted a fraction of what is happening right now. All of the systems out there are creating their own agents, right? And these agents are going to be specialized, but they're there to really address the broader groups, right? Each of your practices or hospital systems have their own way of doing things and need to adapt to those, to adapt to those. And what's nice about these agents now, they're able to actually continuously learn. So we're able to actually have them learn as you go and look at the historical data from learning, but also it can, as you interact with it, it learns from your style, how you like describe your notes, right? It's not rigid anymore, right? That rigidness has gone away. And what the other important part is that you got to understand that, you know, along all the administrative function that you're having to take care of, you know, the interaction with the patient is very key, but also everything that happens in the back office from your admin side, right? All of that has to be smooth running, ensuring that you have the supplies that you need, ensuring that you have the data that you need. The IT teams that go along with it also can benefit from all of these kind of agents. But it's not just agents alone. We've had now for 10 years plus robotic process automation, and that has been very transformative for business process automation. And what does that mean? When you take now these RPA bots and you combine them with these agents, as I said earlier, you're giving them arms and legs. That gives you the ability to now really look at your whole practice end to end, and every bit of the functions can actually be touched by an AI agent and bot to improve the processing and movement, right? Yeah. So that's it. All right. Thank you. Thank you.
Well, thanks to both of our speakers for those fantastic presentations. So now we're going to shift to a panel discussion. Panelists, please join me on stage. Nicolas, that includes you. We're going to start attempting to connect the things that we heard tonight and apply it directly to practice. So joining tonight's speakers are two local physicians, some of you I think know, Dr. Howard Chang and Dr. Jim Joseph, both of whom are integrating AI into their clinical work in unique and individual ways. Dr. Chang's project focuses on applications that support clinical efficiency, while Dr. Joseph's work uses AI to assist patients post-surgery. So together, we'll explore the future of AI in healthcare, what's possible, what's next, and what it means for the profession. We'll have time towards the end for you to ask questions. Those of you who are seated near a microphone, go ahead and push the button when you're ready to ask questions. Those in the back who might have questions, we have some alternatives, so we'll be sure to get your questions as well. All right, with that, I believe Dr. Gangadhar is going to ask the first question.
Yeah, this first question is for Dr. Chang. Howard, I want to know why the vast majority of our medical student class wants to go into emergency medicine. Is it your charm, or is it the AI tools that you're using in the ER?
That's a great question. You know, actually, Kansas Com, I don't know if you guys realize this, but has a lot of emergency medicine presence here. You have Dr. McMaster, which I saw earlier tonight, Dr. Davis, Dr. Carrick, Masasi's here. I mean, there's so much emergency medicine influence, and I think by the time they get to us, they've probably already decided they want to do emergency medicine. And then when they see us using AI technology, like our AI scribing, where they don't have to chart, I think that just seems to do. But I can talk about AI scribing a little bit. So I don't know if you guys remember, but last year, our EHR went down at Ascension, and suddenly we were scrambling. We didn't know how to chart, how to document, how to use paper charts. We had to dig up old systems, T-sheets. We had physicians who had never even handwritten a prescription before. Like, they didn't know what GTT stood for, or like for drops, or any of the abbreviations. It was a whole new world. And so we actually immediately leveraged AI there, and many of us started using an AI scribe app called Savant. And Savant was fairly in its infancy, and what it was a year ago compared to today is completely different. I can talk about Savant. What it is you basically load it up on your phone, you put it down next to you, you talk to the patient as you're just having a one-on-one conversation, making eye contact, all the great stuff that we're trained to do in medical school. And the app just listens to your conversation. And then when you're done, you step out of the room and you hit generate. It's a generative AI app. And then you get to your desk and you load it up, and then it creates a whole chart for you. And I think this first iteration was only so it would like hallucinate things that didn't actually happen. It'd be like, oh, part of my MDM would say, hey, this patient probably doesn't have a pulmonary embolism because the CT scan was negative. And I was like, I never even ordered the CT scan. So there was problems with it. So you had to be very diligent in looking over your charts. But the latest iterations are just phenomenal. You can have 15 differential diagnoses in there. You can have 2, whatever your preference is. It can identify if you're talking to a woman or a man. It can identify that I'm the physician and there's maybe a family member in the room. It can identify different languages as well. So nowadays you can hit generate and the charts are so much better. I can't even imagine what it'll be like in 5 or 10 years. So that's actually something, it actually saved me the other day. The other day I was interviewing a patient, I stepped out. I must have been hallucinating because when I looked at the chart, it said the patient was a renal transplant patient on Cellcept, an anti-rejection medication. And I was like, did they say that? I don't think they said that. And I went back and talked to the nurse, like, yeah, she says she's a renal transplant patient and she's on anti-rejection meds. I'm like, oh my gosh, I totally missed that. I was probably thinking about my dinner or something. But the AI scribe picked it up, I mean, who knows what I would have ordered otherwise. So that's how we're leveraging AI to augment the impact on our practice of medicine. And I can just see this exploding in the next 5 to 10 years. There are many other things we're doing as well but I don't want to hog all the time.
So, Dr. Chang, small question. So when you're talking to the patient, the app is listening to you until their answers.
Yes.
So basically the history is taken.
Yes.
How does it do the physical exam?
Yeah, so there are 2 ways I've done it. I could either listen, like I can listen to the heart and be like, sir, your lungs sound clear and your heart sounds regular rate and rhythm. And I'll just dictate it as I go. Or I step out of the room and I'll dictate a quick physical exam right into the app as I'm walking to my computer, and then it saves it. If you don't say anything, it just makes it up actually. And then it has your favorite physical exam, and you can just save that.
Yeah, it takes care of a patient too. The patient didn't get any better, and the patient wants to file a malpractice case. My question is, can a patient file a malpractice case against AI?
Yeah, I think this is a good question because nobody really knows the answer to this. And it's a question that a lot of physicians have, but ultimately I believe ethically the physician is responsible for the chart. Like, it's your chart, you are the owner of the chart, you signed off on the chart. You can try suing AI, but in my opinion, it's just a tool that we use just like you wouldn't sue the scribe.
Or the stethoscope.
Or the stethoscope, yeah.
Bert, I have a question. The note that the AI generates, can you itemize it? Can you say, I want this much, don't talk that much about this subject, make it short, make it like, every one of us have their own notes, their own style. And it's going to be hard to read a note generated by my AI that is 2 pages long. Can you make instructions like generate a note this short?
The one I use. The question is whether or not I can customize the AI app to be my personal preference, and it is customizable to some extent. I can customize my MDM section the most. Like if I don't want 15 differential diagnoses because it's just not reasonable, I can say I only want 2. If I want this in my history, this in my physical exam, then I can adjust it, I can customize that. But in terms of the history, it seems to be very good at just listening to what the patient says and what you say and sort of summarizing that for you. I haven't found a way to really adjust or customize the history too much. It's fairly accurate though. So if you don't want it to say what you don't want it to, what it says, then you still have to look over it. So whatever it is, whatever app you're using or platform you're using, you have to approach it with some sort of skepticism, at least right now. In this infancy stage of AI, we're in the frontier of AI. So you have to look it over very carefully.
And
Just go ahead.
okay. So for example, what we use, the customization is there at a company level. It has all different specialty notes, etc. But the thing is, each provider, we tell them it's probably going to take you about 2 to 3 weeks to train it the way you want to. So we give them a head start, saying here's a template for your specialty or your hospitalist or whatever. But then eventually you are able to, so between physical exam defaults, assessment plan, how you want them, what we do in the template is you put in examples. Like here's an example of my assessment plan at a default level, right? So this is where you just go ahead and look at all the different options. But yeah, it is getting better and better, but we do have that currently.
So a lot of the tools, like the one I mentioned, the Microsoft Azure Healthcare Data Services Fabric, since it actually is very well integrated with all of the past history based on your past notes, it's actually able to assess that and create a persona style for you. So they're working toward integrating that along with like the Epic tools, so that when you, or many of the others, not just Epic, but one I've seen with Epic as an example. So it can style it that, and then you can also add your own customization, saying, like he said, you can provide and work through that experience. But if you wanted to assess your past history, you can take that approach and say, this is how I've done it in the past, leverage that kind of persona, and then train it that way.
All right. Well, Dr. Gangadhar kicked me under the chair. I guess I better move us along. This question's for Dr. Joseph. You describe your virtual care assistant as a trusted recovery companion. How do you ensure the technology strengthens rather than replaces the human relationship between patients and their providers?
Well, first of all, it's nice to see all the old faces for a while. I'm glad Dr. Milfeld and Dr. Randall's golf game is continuing to improve. This is a little different thing that has been described. This is actually a patient-facing AI tool that I'm working with, the company I'm working with, that was designed by people, not me, people a lot smarter than me. I'm just a clinical advisor for them. So what actually happens is that this is a very niche population for joint replacement patients who often go out into rural Kansas. And as you all know, that's now done as an outpatient. Back in the day, we used to do these and the patient would be in the hospital for a week. Well, now the patient comes into the hospital, has their procedure, and goes home the same day or often the next day. And so they're left with family members, lay people who have to manage those patients postoperatively and oftentimes haven't been trained to do so. So what this is a vehicle for the patient to connect with their providing team through AI. The patients at their clinical team's visit are given access code or an access way to access, including by the phone, that when they get home, if they have questions, they simply enter this conversational AI chat bot, basically. And really, this is a bit of an advancement. It's not telemedicine. It's not a symptom checker. It's not a digital survey of what's going on. It's actually a conversation that the patient enters with AI. And the AI data bank is actually a curated group of messages that is actually done by orthopedic surgeons in the orthopedic literature. So it's not just the Chat GPT data bank. All these questions are filtered through the data bank that's curated. And so that response is given back to the patient. And then it actually enters into some sort of conversation. Eventually, the conversation leads to one of three dispositions. One is that it's a routine post-op course. Don't worry about it. As you can imagine, with the advent of outpatient surgery, my assistant got phone call after phone call the next day. What about this? What about that? And what this does is try to alleviate those things from the assistant, because she would spend hours on the phone. Sometimes patients would call and she's the only person they talk to all day, so they'd spend hours on the phone and she didn't get anything else done. And that has actually happened in our clinical trials as well, where the patients actually become friends with the AI conversation. Some of them actually named them. And eventually they land in one of three dispositions. They either are told that it's normal post-op course, don't worry about it, or the third one is this kind of conversation is going to lead you to the emergency room. So we would suggest that you head to the emergency room, or the more fuzzy one where the provider will be informed of what's going on at the earliest convenience. So it's really just lands in one of three buckets. It's a patient-facing AI
tool that's used so that the patients can actually have some contact. For people in rural Kansas, it's pretty easy. They don't have to go all the way back to town to answer those questions. And so it really provides access, and it's really functions really, to answer your question, as a bridge for patients with their surgical team, so that they don't have to have that 200-mile trip in to just have a simple question answered. Oftentimes they can answer. So the real question now, and we've actually discussed, reviewed this and researched it, is about how well are patients going to receive this type of conversation? How many, this is an old group, this is like us old guys, you know, we're not really technologically savvy. And so we actually studied it, and probably about upwards of this currently, about half the people are fairly comfortable having a conversation with this and understanding this position. So what really has to happen is that the patients need to get more comfortable with it. The doctors need to provide access and assure the patient that we're not providing your care by AI. This is truly clinician covered. The provider knows what's going on. You're not being treated by a computer. And we just want this to be a bridge for you to have access 24/7 without worrying that you'll need to get a call back from the doctor who's busy or out of town or whatever. So it really functions as basically an on-call physician type mechanism by which the patient gets some feedback from a question they have. The vast majority of conversations we've had in clinical trials have been really simple questions that can be answered relatively simply, which is true in clinical practice as well. So it seems to be fairly well received during clinical trials. We're about to have one of our last FDA meetings here next week to get FDA approval for this whole thing. So it's in the development process, but it seems to be coming along quite similarly. I will tell you that during the clinical trials, we actually compared conversations that we've collected, and of course the FDA wants them to have a real doc do that, and the real doc's answer matched the AI's answer about 96.2% of the time. So the AI is answering it just the same way as a group of orthopedic surgeons would answer, probably around 95% of the time, which seems to be fairly acceptable to the FDA at this point.
That other 5% of the time, the orthopedic surgeons are wrong?
Most of the time.
Yeah.
Well, yeah, you ask 10 guys, you get 6 opinions. The problem with this, one of the things is that the orthopedic surgeon in the final product can actually tailor the database to his or her perfect, how she wants those questions to be answered. It was interesting, some of the guys that I recruited to do this, we all had separate ways we handle the same situation. So it can be tailored to the patient, to the doctor's preferences. Yeah.
Nicolas, you talked about how physicians are buried under an avalanche of paperwork and administrative functions, and you talked about saving 20 to 25 minutes a day. So can you tell the physicians in the audience that if they leave here tonight not having AI in their life, in their work life, what's the one thing they should do tomorrow to help get closer to saving that 20 to 25 minutes a day?
Yeah, for me, the easiest one is to really lean into the scribing capability. Having a clip-on, it's been evolving from having the phone to now companies like Nuance who pair up with piece manufacturers that give you a mic like this one. It's a little clip-on you put on, and it's not recording. It's actually listening and instantly transcribing. And then on the back end, the agent is actually analyzing the information, not just to summarize, but to also actually do all the charge coding recommendation, but also on top of that, order the labs for you. Do already, proceed that. So what's happening is the systems are, all the ones that I've mentioned and many more, all the top 10s are working on these kind of integration. They're documenting those workflows, the workflows that you talked about, where you want to look from start to end, the whole thing. And they've been thoroughly looking at that. How do we then take automation and pair that up with these agents to speed things along, right? So as a starting point, that is very key from that perspective. Another close second for me would be for them to start looking at improving things from the admin side, removing the paperwork, removing all of the call it the manual task that that shouldn't be done any longer manually. If they are deterministic in nature, meaning a process that you can systematically write down a procedure you can hand that off to a virtual robot, right? There's no need for you to be doing that. You can be focusing on more strategic thinking, right? So, the clinical side of, assessing and assessment and reviewing then what documentation is producing, right? Yeah.
I have a question for Dr. Patel. How do physicians and administrators really start thinking about how to begin evaluating their needs and deciding whether or not these solutions are right for them?
It's a broad question.
I asked it hard on purpose.
Obviously, it depends on inpatient, outpatient, private clinic versus a bigger organization. But number one is, so I'm going to go back towards like any business person. You're looking at overall the output is on one side, right? I mean, if you want to scale a business, if you want, everyone complains about like Medicare reimbursement, all these things, but ultimately number one is what is the top line revenue? So that's output. And if you know, and I think majority all CEOs know that the clinicians are shackled, that they are not producing at their highest level. And I'm not talking about RVUs. What I'm saying is everyone should be able to practice to their top of their license on every minute that is spent. So even when we do tele or on-site hospitals, for example, the hourly pay for us, if it's a $300,000 salary, that is still, I'm valuing the physician side the same way. Okay. And the reason I want to bring that up is if there's a productivity gap, and a lot of times it comes to, unfortunately, the RVU types of questions for sometimes saying, hey, this physician isn't producing as much, whatnot, or someone is just completely complaining all the time. You need to that is the warning sign saying we need to look at our operations. So I would say that is a financial, employee satisfaction, or operational is you look at it. And what was your second part of the question?
I don't remember. No, my question was, once you've decided whether they're right, how do you think about implementing them?
Yeah, and I think this is where don't overcomplicate it, right? And it goes back to some of these conversations. Right now, we all know the AI scribe thing has been around for a lot of time. That will take care of a lot of your guys' headache right now, and just play around with a bunch of different softwares. I would say if you talk about it, the documentation is probably number one. And honestly, as mentioned earlier, that it does a better job in history taking, to be honest. I mean, there's a lot of times when I look at the HPA, I'm like, man, I did not remember that at all, right? Or I'm too lazy to type all that. So that is the easiest, financially, it's the cheapest thing to also implement, all right? Even if it's a separate thing, it doesn't have to be integrated with your EHR, etc. So it is the easiest thing anyone could do. And that is a great way to start. But then afterwards, when you start thinking about more deeper, that is where I think the user journey comes into play.
Thank you. How about those of you in the audience? What would you like to ask?
So with all the personalization and customization, is AI truly democratic, or is there still a role for super users?
Like, what do you mean?
Yeah.
Like if every doctor can specify how they want their note to look.
Got it. Yeah, so I would say going back to that, how healthcare was built, like when EHRs even try to sell it to the hospital, they say, oh, it's completely customizable. It's actually the worst thing to buy. Here's the thing. You guys are docs. You're not tech folks, right? So the same way, we need to stay in just because something you customize it, that doesn't mean you should customize it. So for example, we're installing Epic at one of our other client hospitals. They're getting just a straightforward Epic. There's no customization conversation. And we should not be having the conversation. You want plug and play. Okay. If they come and sell you not EHRs, I'm just saying anything. Just tell me, can I plug and play and it will take care of my 90% of the problems tomorrow? And it should. And then you take those 10%. So I think that's a really good question. And I think that's where a lot of people fumble, because you don't have the tech background or the type, or even if your tech department isn't, focused on that, they have plenty of other stuff to do.
But when we say customization, it isn't as fact as far as what he was just mentioning. That, I totally agree with what you just said. The customization that I was referring to is with the assistants that you can get now, AI assistant that sits right along the Epics and the others. Those assistants allow you, just like how you talk to ChatGPT and you say, I'm writing this email. Here's what I'm trying to write an email about. Can you customize the voice to word? I'm sending this to a finance person or my legal team or whoever I'm talking to, and then it changes the wording around it. So the earlier question was there is like, I'm transcribing, it's got my notes, but it's being too verbose about this one specific thing. Just like, from ChatGPT, you're conversing with the info, you can converse with that agent and say, hey, can you reduce or summarize this section for me? And it would just do it. That aspect of customization and being able to go back and forth isn't technical by any means. It's just a feature set of the ability to do natural language processing. And that's what these things are really good at, right? Yeah.
I have two questions very quickly.
Yeah.
Howard, you said when you do scribing and then differential diagnosis, it will populate the differential diagnosis, or you tell the system what the differential diagnosis?
No, it just listens to my conversation with the patient. I step out, I hit generate, and it creates a whole number of different, like if I see a chest pain patient, it'll talk about why this is maybe a PE or why it's not a PE, why this is maybe a STEMI or why not a STEMI, why this is not a ventricular rupture, etc. And it'll just go through this whole line by line, and you can say, I want 12 of them per chart, or I want just 2 of them per chart, or I want 0 of them per chart. Everyone's customizes their chart a little differently.
The second question for you guys, let's say I have eClinical as my AMR and I'm doing the scribing. It integrate with the system or it replace the system?
No, it doesn't replace. Yeah, it's definitely an integration aspect, right?
Integration aspect.
It's an integration aspect. And what these agents now, they're getting expanded to the point with automation to be able to talk directly to those systems. And if that system isn't ready yet, that's where RPA comes in. It can actually interact from the front, right? It can sit right there beside there as an attendant robot and then do the things for you, right? So there's always avenue to get over the integration hump, essentially, if you don't want to go with the back end until it's ready, right? So, yeah.
Okay. I am also getting kicked under the table. Tori and Philip are kicking me under the table. So we do need to wrap up the evening. But we want to finish out with rapid fire. Okay. So please, if you would, finish this sentence. In 5 years, AI will have made healthcare, Howard?
5 years, AI would have made healthcare scarier. Yeah. Well, one of the things that we all talk about is how AI will save us time. I want to spend 50% less time charting. I want to spend 50% less time working on creating schedules for all my docs. But what if I have a bad employer? What if I work for a private equity company and instead it says, wow, Dr. Chang, you have so much free time now, go see more patients. And now I'm just stuck seeing more patients over, which is fine, but I would rather spend more time with the patients I currently have. So I don't know what's going to happen. So it's a bit scary for me.
Okay. Nicolas?
To me, actually, I agree to that extent, but I think it's evolving so quickly. I think we'll get over that hump sooner than later. Within 5 years, I think it will be quieter. It'll be more calm. And we're going to be reclaiming so much time, we said, like productivity, that you can actually, let the doctor recharge, right? Give them the ability to recharge and be a lot more effective in their practice. Yeah.
Sarjoo?
I would say it would give healthcare back to the clinicians. Okay. But it's going to come down to how they leverage it. Yeah. And, I think big organizations different, but if you have a direct primary care, if you want to go solo by yourself, and do your thing, and I mean, you design your day, right? I think it puts the soul back into healthcare.
Jim?
Well, I would just say that, just a statement that AI won't replace physicians, but physicians who use AI will.
Very good.
Good point.
Well, let's give a hand for all of our panelists. And on behalf of all of us at Kansas Com, I want to just give a personal thanks to the Medical Society of Sedgwick County, Philip Brownlee for making this happen, Tori for all the work she's put into it, our past president, Howard Chang, our current president, Johnny Musa, and our incoming president, Chadi Saraf. So I think one thing is for sure, we are just at the tip of the iceberg. And it's not just medical care that will be completely revolutionized with AI. I think it is medical education also. So exciting times ahead. Thank you for being here and have a great night.